Kidney is a very important topic. Urology, in urology, we'll be discussing about first the kidney, then the ureter, then the bladder, then the urethra and prostate. These are the order we will go. Kidney and ureter, bladder, prostate, urethra and miscellaneous topics like testis, penis, trauma. This we will discuss in urology. So first we'll discuss about kidney and ureter. The first topic is kidney and ureter. Okay. So in kidneys again, the questions will be asked: congenital abnormalities, cystic diseases, infections, stones, trauma and neoplasms. Out of these three are the most important: infection, stone and neoplasm. Stone, you consider one question is a guarantee from stone. So first we will start with renal stone. Okay. So can anybody name one congenital abnormality of the kidney? One congenital abnormality of the kidney.
Infantile polycystic kidney disease.
Sorry.
Infantile polycystic kidney disease.
Infantile polycystic kidney disease. Okay, good. That will do in cystic diseases. Cystic diseases, infantile and adult. Polycystic kidney disease.
Horseshoe kidney.
Yeah, very good. Congenital abnormalities, horseshoe kidney, renal agenesis, duplication. These sort of things will come in congenital abnormalities. They are present from birth. Okay, horseshoe kidney, renal agenesis. The kidney is absent, unilateral or bilateral, or it may be duplication. Sometimes the single kidney will be duplicated into two prongs, upper part and lower part. That is duplication. Cystic diseases is infantile and adult. And infections. What is the infection of the kidney known as?
Pyelonephritis.
Pyelonephritis.
Yeah, very good. Pyelonephritis. So, any other types of pyelonephritis you know of? Acute and chronic, that is one. Acute pyelonephritis, chronic pyelonephritis. Apart from that, any other things you know of?
UTI and cystitis.
Sorry, emphysematous pyelonephritis. Yeah, very good. Emphysematous pyelonephritis. Xanthogranulomatous pyelonephritis. This we will discuss here. What is emphysematous pyelonephritis? Emphysema is simple. Emphysema is presence of emphysema. The subcutaneous emphysema we call presence of gas subcutaneously. Okay, so emphysematous pyelonephritis is gas in the kidney. Gas forming organisms produce gas in the kidney. Okay, so if there is gas forming organisms, then the infection is known as emphysematous pyelonephritis. Then stones we'll discuss in detail. Renal trauma we'll discuss, and neoplasms. Name one neoplasm of the kidney.
Renal cell carcinoma.
Renal cell carcinoma. Very good. It is a malignant tumor. Renal cell carcinoma. Okay. So to make it little interesting, see, I am basically a urologist. So emergency admissions in urology ward will be only 3. There will be no much disturbance to your sleep in the night. Only 3. Patient may come with renal pain, colic. Patient may come with colic. Patient may have blood in the urine, or patient may not pass urine, urinary retention. These are the 3 complaints with which the patient will come in emergency. Okay. So out of this, the first one we'll discuss in detail: ureteric colic or renal pain. We call renal colic. Is it correct? The term renal colic. Is it correct? Yes, no. Anything is accepted?
Yes, sir.
Okay. But there is no term called renal colic. We generally tell the patient came to the hospital with renal colic, but there is no term called renal colic. Why? Because see, this is the kidney, this is the ureter. Colicky pain. What is colicky pain? Colicky pain arises in which structures?
Tubular structure.
Tubular structures. Very good. Colicky pain always it arises in tubular structures. So this is the ureter. If a stone is lodged here, what will happen? Why this pain will arise? Colicky pain.
Some obstruction, stone
Yeah,
or
obstruction is there. Very good. So
so
tubular
the
structures, what will
urine.
be there?
Due to the movement of the caviculi,
Yeah, what is that movement? Yeah, very good. Very good. What is that movement known as? Peristalsis.
peristalsis,
Okay. So wherever intestine or in the gallbladder, in the bile duct or in the ureter, what will happen is, if there is imagine a tube, there is an obstruction below. What will happen is, the tube will try to move itself. It will cause peristalsis. Okay. Because of this peristalsis, there will be accumulation of fluid inside. It is unable to dispel the stone outside. So there will be accumulation of fluid inside, and which will cause the colicky type of pain. So there is nothing called renal colic. If the stone is lodged here, there will be no colicky pain because it is not a tubular structure. Kidney is not a tubular structure. What is the type of pain here? It is dull aching type of pain. Dull aching type of pain. Okay. This is colicky pain. There is a difference between these two. Just try to remember this and differentiate this. Okay. So there is a stone in the kidney, there is a stone in the ureter. How to differentiate? Differences. Kidney stone, ureteric stone. One difference I already told you. What is the first difference?
pain, colicky pain, and
Yeah, type of pain. Type of pain. That is type of pain. It is dull aching type of pain. Dull aching type of pain. It is colicky type of pain. That is the first difference. Second is severity. Kidney stone is mild. It will be constantly present, but it will be very mild. Okay. The patient will be accepted. The patient can live with it. But ureteric stone, it is severe. The patient will complain of severe pain. Okay. This is about severity. The type you know, severity you know. And the other is periodicity. Periodicity is kidney stone is continuous. Whereas colicky pain is kidney pain is continuous. It is always present, dull aching, mild, continuous pain. But colicky pain, it
episodic.
Yeah, episodic. It is intermittent, comes and goes. Whenever there is obstruction, whenever the stone is lodged, it tries. Whenever there is peristalsis, pain will be there. Otherwise, there will be no peristalsis. So it is episodic type of pain. Okay. So these differences you must know. These three differences you must know. Dull aching type of pain, kidney stone. Mild, kidney stone. Constant, kidney stone. Colicky type of pain, ureteric stone. It is severe, ureteric stone. If it is episodic, intermittent, it is ureteric stone. Why this is important is, just they will give these three features and identify to, and I tell you to localize the stone. So this is very important symptom wise. So there is no term called renal colic. Remember, there is a term called ureteric colic or renal pain. There is no renal colic. Just make sure with that. This is done. Okay. So what is this concept of referred pain, and why you should know that? What is referred pain? Anybody?
Pain present at the pain at the non-problematic site.
Pain at a
The non-problematic site where the problem doesn't lie.
See, there is a anatomical site where the pain originates, but there is another other organ somewhere where the pain will radiate because of the nerve supply, dermatomal supply, neurotomal supply. Okay, so because of this neural supply, the pain will radiate there. So why you should know that? What extra benefit you will get?
Is to find out exactly where the stone is lodged.
Yeah, very good. So it is an indicator. It is an indirect indicator so that we can find where the stone is lodged. Okay. So see here. This is the kidney. This is the ureter. What is the junction known as? The junction between the kidney and the ureter.
Pelvic.
Pelvic-ureteric junction. Very good. PUJ. Okay. See, suppose the stone is in the upper ureter. The stone is in the upper ureter or in the renal pelvis. The pain is referred to the testis. Okay. So if young male comes to our OPD, he will tell, sir, there is pain here, and sometimes I feel there is pain in the testis also. Then you will think that the patient will have upper ureteric stone. It is not a simple case. It is an upper ureteric stone, or it is the stone is in the pelvis. Okay. So this is the importance of this referred pain. That is that. And stone in the mid ureter. Stone in the mid ureter, it is referred to iliac fossa. If it goes to the right iliac fossa, you will think of appendicitis. Okay. It will be mimicking appendicitis. The pain will be referred to the right iliac fossa. You think that stone is in the right mid ureter. And stone in the lower ureter. This is mid ureter. This is the lower ureter. If the lower ureter is there, the patient will have pain along the thigh, the scrotum, the perineum. Okay, along the inner aspect of the thighs, the scrotum, the perineum, the patient will have pain. If the patient will have stone approaching the bladder, there will be bladder symptoms. What are the bladder symptoms like? 1, 2, 3. Can anybody tell me? Name some bladder symptoms. Just think, what will be the bladder symptoms? Think and tell. Wrong also is okay.
Micturition.
Micturition, yeah. There will be frequency. Normally there will be normal micturition will be there, but these patients will be, if the stone is nearing the bladder, they will have frequency of micturition. That is, multiple times they have to go to the washroom because the stone is near. It will be constantly irritating the bladder. Okay, there will be frequency. This is the, so see in the question, if they give you a patient with colicky type of pain and frequency of urine and all other bladder symptoms, identify the stone location. Upper ureter, mid ureter, lower ureter, approaching the bladder. So what is your answer? Come on.
It would be lower ureter.
Lower, or if it is approaching the bladder, if that is there, it is, the answer is approaching the bladder, because they are given clearly, if it is near the bladder, bladder symptoms will be there. Okay. And finally, if the stone is in the intramural ureter, what is this intramural ureter? Can anybody tell me what is this intramural part of ureter? Yeah, intramural part of ureter. Just guess. See here, this is the ureter. The upper part is the ureter. It goes below, and here it opens into the orifice. Okay, this part of ureter which lies within the bladder is known as intramural ureter, which is known as intramural ureter. Okay, so this is the kidney, ureter, within the bladder, that is intramural ureter. So if there is intramural stone is lodged here, there will be strangury. What is the strangury term? Strangury. Strangury. Block. No, no. It is not block. Strangury is nothing but, it is painful micturition is strangury. Painful micturition is strangury. Okay. Just remember this term. It will be asked multiple times. Painful micturition. It is known as strangury. Okay. And what is this painful defecation known as? Anybody can tell me? What is this painful defecation known as? Starts with T. I am giving the clue also. Painful defecation known as?
Tenesmus.
Very good. Excellent. Tenesmus. Very good. Okay. So this is about the importance of referred pain. So just you have to remember, if the patient is having pain in the testis, upper ureter or renal pelvis, mid ureter, iliac fossa, Lower ureter, it is along the thigh, scrotum, perineum. Approaching the bladder, bladder symptoms like frequency, urgency. If it is in the intramural ureter, it is strangury, that is painful micturition. And I told you the next level, that is for even if you want to prepare further, then you have to know about these nerves also. They are never asked in our FMGE, but if you want to go for little further, see in the mid-ureter, the nerve name also they are asking. It is iliohypogastric nerve, mid-ureter. In the lower, if it is the thigh perineum, the nerve is ilioinguinal nerve. Ilioinguinal nerve. Okay, these two things, little extra point. Okay. So this is just a diagrammatic representation. Narrowings of ureter. Narrowings of ureter. In anatomy, we will see some narrowings, anatomical narrowings. They are not pathological, they are just anatomical narrowings. So what is the importance of these narrowings? Why we should know about these narrowings?
It's the point where the stones could be lodged.
Is the point where?
The stones could be lodged.
Very good. So see, whenever there is a narrowing, the stones are prone to lodge there. Day after tomorrow, we'll be discussing about esophagus. Esophagus also, there are some anatomical narrowings, constrictions. What is the importance of that? Esophageal narrowings. Here it is stone. There it is. Esophagus also, there are some narrowings which we'll discuss. What is the importance of that?
Constructions.
Sorry?
Constructions.
Yeah, constrictions. But what is the importance of that? Here, narrowings are there. Stones are there in the narrowings. There in esophagus.
Food bowls will be blocked.
Okay, food and something else in pediatrics, in children, what will happen?
Foreign body.
Yeah, very good. There will be foreign body. They will take something. Foreign bodies will be there. So at these narrowings, we have to search. Whenever we do endoscopy, we have to search at these narrowings, anatomical narrowings. Okay. Day after tomorrow we'll discuss that. Okay. So what are the various anatomical narrowings of ureter? One is the uretropelvic junction above, uretrovesical junction below, UPJ, UVJ. Uretropelvic junction, uretrovesical junction. And third is crossing of the iliac artery. Because the ureter is here, the iliac artery will be crossing over it. Okay, so there will be narrowing there, crossing of the iliac artery. Juxtaposition of vas deferens or broad ligament. That is, whenever the vas deferens is there or broad ligament in females, vas deferens in males. Okay, there also there will be narrowing. And finally, while entering the bladder wall also, it will be narrow. These are the 5 anatomical narrowings where the stones are more prone to get lodged. Clear? One is uretropelvic junction. One is crossing of artery. Other is crossing of vas. Other is entering the bladder. And other is ureteric orifice. Okay? You have to remember this. In image-based questions also, they may ask you. Till now clear? Any doubt? Please answer in the chat box. Others also. Okay. So now we'll learn a concept called Deightel's crisis. Deightel's crisis is nothing but, see here, what will happen is a stone is lodged here. The stone is lodged here. So there will be obstruction to the urinary flow. The urine will get accumulated here. The kidney will get swollen. What is that? Kidney swelling. Swelling of the kidney is known as swelling of the kidney, enlargement of the kidney.
Hydronephrosis.
Hydronephrosis. Okay. And because of hydronephrosis, the patient will have severe pain here. Because of this hydronephrosis, the patient will have severe loin pain. Okay. And then what will happen after some time? The stone will get dislodged. Because of the accumulating pressure here, the stone will get dislodged. It will move. In the kidney, there is a lot of space. It will move. Then what will happen? The patient will pass lot of urine. The swelling will decrease. The pain will decrease. This entire concept is known as Dietill's crisis. Okay, this entire concept is known as Dietill's crisis. It is nothing but, in single word, if you want, you put intermittent hydronephrosis. Hydronephrosis is intermittent. Whenever there is block, the kidney will get swollen. The patient will have pain. The patient will not pass urine. The stone moves. The patient will pass urine. The swelling will decrease in size, and the stone is dislodged. The swelling will decrease. The pain will also decrease. This is known as intermittent hydronephrosis. Okay, and most common cause of ureteric obstruction is stone. See here, this is an MCQ. They are asked frequently. Most common cause of obstruction, ureteric obstruction. If this is the ureter, this is the kidney. The most common cause of obstruction is stone. But if in the question they mention most common cause of ureteric colic in hematuria, if they clearly give it as hematuria, then it is not stone, but it is a clot. Clot also can cause renal colic. Sorry, ureteric colic. Okay, so just tell me, what is Dietill's crisis? One word answer. What is Dietill's crisis?
Intermittent hydronephrosis.
Intermittent hydronephrosis. Very good. Then what is the most common cause of ureteric obstruction?
Stones.
Most common cause of ureteric obstruction in hematuria patient?
Clot.
It is clot. Okay. So with this important points, we have discussed about referred pain. We have discussed about ureteric narrowings. We discussed about Dietill's crisis, and now we'll move on to stones. How do the stones form? What are the various type of stones? How will they present? How to investigate? When to treat? And how to treat? These are the common questions we have in our mind. So the ones which are given in green, how do stones form? How will they present are not important. Exam point of view. What are the types in red? How to treat? It is very, very important. Exam point of view. How to investigate and when to treat is also important. So can anybody tell me, how do the stones form?
Due to the calcium deposition.
Sorry?
Crystallization.
Due to chronic dehydration.
Supersaturation of
Yeah, supersaturation. Very good. One word answer is supersaturation. Very good. Supersaturation. So it is supersaturation of solution. So just a simple example which we learn in our physics. Take a solution, add salt. What will happen initially? If you add salt, what will happen?
Saturation.
Sorry?
dissolves in water.
Yeah, it dissolves in water. If you keep on adding the salt,
After a point, it gets saturated.
yeah, the solution gets saturated. So what will happen after that? It gets precipitated, and then it forms, it enlarges, it crystallizes, then it forms into crystals, and finally it forms into stones. This is what is the same thing happening in the kidney also. Whenever you take some substances, whenever there is some excess of substances, the kidney will try to dissolve it. Okay, the kidney will try to dissolve it in the urine. Even if you further take so much of substance till you are abusing it, then there will be precipitation of the salts. After this precipitation, if you still keep on doing like that, if the patient will still not correct it by taking much adequate water, or if he is not hydrated properly, if he is still dehydrated. So what will happen is the stones will get crystallized. It will be crystallizing. It will grow, aggregate. It will aggregate into bigger stones. Okay. Apart from that, there is this supersaturation is one thing, and the other thing is There are certain substances called promoters and inhibitors. Promoters and inhibitors. What are these promoters and what are these inhibitors? Can anybody tell me? One promoter it promotes stone formation. Calcium, very good. Oxalate, cysteine. These are the three main important promoters. Inhibitors, one inhibitor at least.
Citrate.
Citrate, very good. Citrate is the single inhibitor. Okay, so citrate is abundantly available in which water? In which solution?
Lemon solution.
Yeah, lemon solution. So that's why we advise the patients with stone to drink lot of lemon water, vitamin C. Okay, so it contains citrate. Okay, so that is about stone formation. You have two theories. One is supersaturation theory. One is inhibitor promoter theory. Okay, whenever there is imbalance between these two things, promoters and inhibitors, there is stone formation. What are the various type of stones?
Calcium oxalate.
Good.
Struvite.
Good.
Cysteine.
Very good.
Uric acid.
Yeah, excellent. So these are the 4 type of stones. So this slide, just everybody make sure that this slide you concentrate. Calcium oxalate type of stone, struvite type of stone, cysteine type of stone, uric acid type of stone. Sorry. Calcium oxalate is the most common type of stone. Calcium oxalate, most common type of stone. That is the first 5 points for each you will just discuss. 5 points. It is found in acidic urine. It is found in acidic urine. It is the most common type. And what is the shape of calcium oxalate? Yeah, it is calcium oxalate, monohydrate, calcium oxalate, dihydrate. 2 types of stones are there. Monohydrate, single oxalate, dihydrate, 2 types. So monohydrate is dumbbell shape. Dihydrate is envelope shape. Remember, envelope you have to send it to someone. 2 people are involved. So it is envelope shape. Dihydrate. Monohydrate is dumbbell shaped. Calcium oxalate, it is the most common. It is formed in acidic urine. It is envelope shaped or dumbbell shaped. Okay. And it is radio opaque. What is this radio opacity and radiolucency? What is the term radio opaque? What is radiolucency?
It's visible as white in X-ray,
Yeah.
radio optic.
If it is visible on X-ray, it is radio opaque. If it is not visible, it is radiolucent. That's it. So coming to struvite stone. Struvite stone, other names are important. It is also known as infection stone. It is known as calcium, ammonium, magnesium phosphate stone. It is known as staghorn stone. These are the other names. Okay. Infection stone, calcium, ammonium, magnesium phosphate stone, or staghorn stone. It forms in which urine? Acidic urine or alkaline urine?
Alkaline.
Why? Good, but alkaline only. But why it is alkaline? In acid, do organisms grow in acid?
No.
No. So this is an infection stone. This stone is due to infection, organisms. So it is alkaline urine. This is also radio opaque. The shape is, can anybody tell me the shape of the stone? Strovine, infection. It is dangerous. It is death.
It's a
It is
staghorn.
staghorn. It is not a
Coffin
shape.
crystal.
Staghorn
Coffin
is the other name. It looks like staghorn, but the shape is coffin lid.
Coffin lid
Coffin
crystal.
lid crystal type of stone. Coffin lid. It is dangerous. Just remember, coffin lid. It is death. Infection is death. Okay. Then coming to cystine type of stones. Cystine are the special point regarding this is it is very hard stone. It is not amenable to ESWL. What is ESWL? I'll discuss. It is very hard. It will not break ESWL. And it also cystine stone is seen in acidic urine. It is not alkaline, it is acidic urine. And cystine stone, what is the shape? Sorry, I'll show you the shapes.
It's an hexagonal.
Yeah, see here, this is the calcium oxalate stone. This is envelope. Calcium oxalate is envelope. It is calcium oxalate dihydrate. Staghorn, it is coffin lid. Hexagon is cystine stones are hexagonal. And uric acid, I'll tell you. Uric acid we'll discuss. Okay, this is hexagonal. Cystine is hexagonal. And this is also radio opaque. Whereas uric acid, it is in a disorder. Which disorder? Uric acid.
Gout.
Yeah,
Gout.
uric acid is increased in gout. Okay, and one syndrome, Leishman syndrome. Very good. This remember there's two things in gout, in Leishman syndrome. This also in acidic urine only. This also in acidic urine only. And shape is rhomboid type of shape, rhomboid crystals. And this is radiolucent. This is radiolucent. Clear? It is not visible because see all the other salts, calcium, struvite, cystine, all the other salts they are heavy salts. They can be seen on the X-ray. Uric acid, it is a very light salt, so it can't be seen on X-ray. So remember, radiolucent stone. Is this slide clear to everyone? 5 points. So total we discuss 20 points, 5 into 4. For each stone we'll discuss one point. So 5 into 4, 20 points. 1 point is must in your exam. Yes, no?
Yes, sir.
Okay. So just answer me then. Which stone is formed in alkaline urine?
Struvite stone.
Which stone is others also? Which stone is radiolucent stone?
Uric acid stone.
What is the other name of staghorn stone?
Infection stone.
One.
Calcium magnesium ammonium phosphate stone.
Okay.
Struvite
Staghorn.
stone.
Staghorn, struvite stone. Okay. So it is also known as triple phosphate stone because three for calcium, ammonium, magnesium, phosphate, right? So it is known as triple phosphate type of stone. Okay. So these are the types of stones. How will they present? Next point is how will they present?
Pain.
Yeah. One. Others? Other findings. What are the other? How will the patient will present? The patient has stone, he has pain. Other findings?
He can step in.
urine,
Yeah.
Burning
Pregnancy
inflammation.
and all. Okay. Good. Bladder symptoms will be there. Nice. Then important. One more important feature of stone. There is blood in the urine. What is that?
Hematuria.
It will
Hematuria.
present with hematuria, right? So these are the three presenting features. Okay. How do the stones form? This we have discussed. Supersaturated solution and promoter inhibitors. What is citrate?
Inhibitor.
Inhibitor.
Yeah, it is the most common inhibitor, stone inhibitor. And see this image based question. They'll just give these images. These are Randall's plaques. These are some normal. They'll be. This is from inside. You have seen the kidney from inside. So Randall's plaques are soft tissue calcifications. They are nothing but their tissue calcifications found in the renal medulla. Okay, they act as nucleating elements for renal calculi. Whenever they are there, surrounding this, the salts will be deposited. Okay, so this acts like a initiating factor. This is Randall's plaque. So these are the various type of stones we have discussed. Any other point we have left, we'll discuss now. Calcium oxalate, most common type of kidney stone, 85%. Risk factors are hypercalciuria, hypercalcemia, hyperoxaluria. Whenever the calcium is increased, whenever the oxalate is increased, stones will form. They have the, how is the, see here, this is the calcium oxalate. See here, this. They have, if the stone is like this, they have hard surface, jagged surface. So they have other name called, can anybody tell me? Because of this shape, they have other name. See here. Because of this hard, small, jagged surface, they have another name. They are known as mulberry stones. Mulberry stones. Okay, and because of this jagged surface, which is most common? Or what symptom will be there because of this jagged surface?
Hematuria.
Hematuria will be there. Okay, yeah. So, which stone? Another MCQ. Which stone will have maximum hematuria is calcium oxalate because of this jagged surface. Stoveite stones, just now we have discussed, they are composed of calcium, ammonium, magnesium. They are known as triple phosphates. They tend to grow in alkaline urine. All the other in acidic urine except this alkaline urine. Remember, they are known as staghorn stones. They are most common in women. They are most common in. They are most commonly seen in women. Why in women?
It is short urethra.
Yeah, very good. Urethra is short. What is the length of urethra?
4 centimeters.
4 centimeters. Yeah, very good. So the length of female urethra is 4 centimeters. Whereas in males it is
20 centimeters.
20 centimeters. Okay. So this is a.
The highlighted ones in yellow are not clearly visible.
Okay. Okay, but it is just this yellow, right?
Just
If possible, to put another color while teaching, so it will be useful.
Yeah, from maybe from tomorrow I'll do it because today the PPT is prepared.
No
Okay,
problem.
whenever I'll just I'll tell you that. Okay,
Okay.
I'll tell that point. Okay, so here see the increased tendency to form stoveite calculi. This is stoveite calculi. This is a staghorn. The stones will be like this. See, this is an X-ray image. The stone will be resembling a staghorn. Maximum points we have discussed already. Okay. Cystine. This is cystine. It is very extremely hard stone found in acidic urine. It is relatively resistant to fragmentation by ESWL. I'll tell you what is ESWL. So this has a ground glass appearance. This see the corner image. These are ground glasses. The stone looks like ground glass. Cystine stones, very hard. Uric acid. They are only 5 to 10% of stones. They are most common radiolucent stones. They are found in acidic urine, gout, and Leishman syndrome. Xanthine, this is not necessary. And I'll ask you, what is the most common type of stone? Renal stone.
Calcium.
Oxalate.
Most common radiolucent type of stone.
Uric acid.
Uric acid.
Very good. So, other radiolucent stones. Lucent. L is lucent. U is uric acid. X is xanthine. I is indinavir. T is triamtrene. Triamtrene. So these are the 4 type of stones: uric acid, xanthine, indinavir, and triamtrene. Where is this indinavir used?
HIV.
HIV.
Yeah. So these are the 4 type of stones like uric acid, xanthine, indinavir, and triamtrene. These are all radiolucent. Okay. Out of this, the most common is uric acid. Clear?
Yes, sir.
Yeah. Then how to investigate and when to treat? Do all stones require treatment? No. Okay, surgical treatment, I mean. Most of the stones will have medical management only. How to investigate and when to treat. So they have two modalities. One is ultrasound. One is NCCT. What is this NCCT?
Non-contrast.
Yeah, non-contrast computed tomography. This is the investigation of choice. This is the investigation of choice. Here another point is investigation of choice is NCCT. This is the investigation of choice for other two things, other two important pathologies. One is head injury. For head injury also, non-contrast CT is the investigation of choice. Other is submandibular stones. Submandibular stones. For this also NCCT is the investigation of choice. For three things only, this is the investigation of choice. Plain CT. One is kidney stones, submandibular stones, and head injuries. Clear? These are the additional points just I am covering so that it will be useful to you. I am just deviating. Is it okay? No problem.
Okay, sir.
Yeah. How to investigate is ultrasound and non-contrast CT. And when to treat. Based on the size of this size, one is the size criteria. If the patient is having recurrent pain, if the patient is having recurrent infection, if the patient is having obstruction, urinary obstruction, these are the four things which we will take into consideration before we operate on a patient. One is size, one is pain, one is infection, one is obstruction. Okay. So size. In the kidney, it is 1 centimeter. Kidney, it is 1 centimeter. Ureter, it is 6 to 7 mm. Less than that, we can try for medical expulsive therapy, medical management. If it is more than 1 centimeter in the kidney or more than 7 mm in the ureter, then we have to go for surgery. Or if there is pain, if there is infection, if there is obstruction, we have to go for surgery. Clear? Yes, no?
Yes, sir.
Sorry, so what I understand is if the stone in the kidney is more than a centimeter, then you go for surgery. Is that what you're saying?
Yeah. In the kidney, if the stone is more than 1 centimeter, in the ureter, if it is more than 6 to 7 mm, there is no clear cutoff. If it is more than 6 to 7 mm, the chance of stone getting out is very rare. Okay. So we have to go for surgery.
Okay, got it.
Yeah. And the other things are pain, infection, obstruction. If these three are there, also you have to go for surgery. Okay.
Sir, in
Yeah.
one of the previous slides, it had mentioned, you had mentioned this point, Staghorn calculi are silent. What does that mean, sir?
Yeah, very good. See. This is the kidney. This is the stone. Staghorn stone. It is completely occupying the entire pelvis. So what will happen is, if there is some space inside the pelvis, urine will flow through it. Okay, urine will flow through it and the patient will have pain. But in Staghorn, the complete PCS, the pelvic cholesterol system, is packed with stone. So there is no chance of that patient complaining of pain. So the patient is asymptomatic. Okay, so that's what I meant in the patient is, the stone is silent. That is, it is not making any disturbance to the patient. But how come we will know is, we will do an ultrasound for some other reason. For suppose the patient is having some gastritis, the patient is having some appendicitis, some other reason we'll do an ultrasound and we'll identify that huge stone. Okay, that is one. Or the patient may come with renal failure. If he is having bilateral stones, he will come with renal failure, decreased urine output. Then also we will identify this Staghorn stones. So the patient will be not presenting with pain. That's what I meant is silent. Okay.
Okay, sir. Thank you so much.
Okay. So shall we take a small break here, so that we'll go into management of stones.
Okay, sir.
Sir, can you please show the table once again? The stone.
This table.
Yes, sir.
Okay. Shall I tell it?
Yeah, it's fine, sir.
Yeah. Calcium oxalate, struvite, cysteine, and uric acid. These are the 4 types of stones. Out of this calcium oxalate, the most common is calcium oxalate. Cysteine, the other names are infection. calcium ammonium magnesium phosphate, also known as triple phosphate, staghorn. Cysteine, the special point for this is it is the hard stone, it is resistant to ESWL. And uric acid, it is seen in gout or any myeloproliferative disorders like Lesch-Nyhan syndrome. And calcium oxalate, it is acidic in urine. See, all the other stones are acidic. It is also acidic, it is also acidic. Stobite is in alkaline urine. And calcium oxalate, it is calcium oxalate monohydrate is dumbbell shaped. Calcium oxalate dihydrate is envelope shaped. Stobite stone is coffin-lid crystal type of stone. And cysteine is hexagonal. Uric acid is rhomboid. All the other type of stones are radio opaque except for uric acid. It is radiolucent. And the most common radiolucent type of stone is uric acid. What are the other radiolucent stones? Other radiolucent stones.
Xanthine,
Okay.
triamph.
Yeah, triamptrin. Very good. Very good.
Triamptrin.
Okay. Good. Okay, is this clear? The table you asked for?
Yes, sir.
Yeah, it's very important. Just afterwards, also is there in the notes also, and many questions can be answered with this simple table. Okay.
Okay, sir. Thank you.
So this is just dietary modifications in stone disease. Not important from exam point of view. Just increase intake of fluid to decrease supersaturation. Dietary calcium, potassium phytates, vitamin C. It is increase intake of dietary calcium. Okay, so that it will bind with oxalate and it will not crystallize. Okay, it is we have to increase the intake of dietary calcium, not routine. Our whatever available in our diet, we can take that, consume that calcium, but we have to not take calcium supplements. And decrease intake of oxalate, animal protein, sucrose, fructose, and sodium. We have to decrease the intake of these things. Surgical options. Can anybody tell me how to manage with a stone and what are the indications of stone surgery, which now we just now discussed? Indications for stone surgery.
Pain, infection,
Pain,
Size of the
infection,
stone.
Pain, infection, obstruction.
yeah, pain, infection, obstruction, and size criteria. So, what are the various options available?
lithotripsy, invasive, non-invasive.
Yeah, invasive, non-invasive. Okay, but earlier days, for anything, open surgery was the option. For even a 8 mm stone, they used to open the abdomen, go into the retroperitoneum because it's not in the peritoneum. This is retroperitoneum. Go there, open it, take the stone out. This used to be the process. Okay, in earlier days, open surgery. But nowadays, we have minimal invasive options, minimal invasive surgery. What is this minimal invasive surgery?
Urethroskopy.
Sorry?
Urethroskopy.
Yeah. So, see, we'll discuss in two headings, one in kidney, one in the ureter. So, first we'll discuss about the kidney stones. So, what are the treatment options for kidney stones? One is ESWL. One is PCNL. And the other is RIRS. What are these? I'll tell you, but just remember ESWL, PCNL, RIRS. So, suppose the stone is here. Just for simply, you are breaking it from outside. You are giving some shock waves. You are not incising at all. You are asking the patient to lie down on a machine. You are giving some shock waves from outside, and you are breaking that stone. Okay, that is known as
Lithotripsy.
extracorporeal shock wave lithotripsy. That is the first one. Second thing is percutaneous nephrolithotomy. You will make a hole in the kidney, put a scope inside, fragment the stone, and take it out. That is percutaneous nephrolithotomy, PCNL. and the other is RIRS. Can anybody name what is RIRS? RIRS. It is a newer surgery in urology, so it may be asked. Full form of RIRS.
Retrograde intrarenal surgery.
Retrograde intrarenal surgery. Excellent. You put a scope from here, retrograde. You go there, you fragment it and take it out. So these are the three modalities available for dealing a kidney stone. So this is ESWL. See, the patient lies down on this machine. This is the C-arm to localize the stone, and you hit the stone from here. You hit it from here. Okay, with high energy shock waves. Okay, you give high energy shock waves and hit the stone. Okay, so this is known as extracorporeal shock wave lithotripsy. The name itself is telling extracorporeal shock wave lithotripsy. Okay. So this is the kidney and this is the stone. This is one stone A, stone B. So, and this is stone C. Which stone is easily approachable with ESWL? But which stone is difficult with ESWL? You are giving shock waves from here. Outside you are giving shock waves. Easy. Which is easy?
The stone A and C should be easy because it's on the periphery.
No. Stone A and B are easy and C is difficult. Why it is difficult? Because of its lower anatomical location, lower pole anatomy. Kidney is having three poles, right? Upper pole, mid pole, and lower pole. The lower pole stones are difficult because once you fragment it, it should go out, it should expulse out. Okay, so it is difficult for the stone to get expulsed outside. Okay, so why? Because of its anatomical location, lower pole anatomical location. Upper pole, the gravity will help for the stone to get cleared, but lower pole, because of its anatomical location, it is difficult. This is one difficulties. Okay, one is anatomical lower pole location. Can anybody tell me which other stone is very hard, which other stone is difficult for ESWL? We discussed.
Uric acid.
Cystine, not uric acid. It is cystine. It is type of stone. And third is type of patient. See, an obese patient is there, obese patient and a thin patient. In whom ESWL work, which will work better? Thin patient, obviously, right? Because you are giving shock waves here. So this should go along this fat, that the shock wave will get dampened. Whereas thin patient, it will go directly. Okay. So these are the important things. Anatomical location of the stone, type of patient. So these are the difficult or hard stones. Difficult or hard stones for ESWL. One is brucite, one is hydroxyapatite, one is cystine, one is calcium oxalate monohydrate. These are the difficult stones. Okay. Clear? Just remember this. And whenever there is reduced clearance, the stone is in the lower calysteal location. One, the stone is in a diverticulum. Suppose it's a diverticulum here. If the stone is there, it will be difficult. Horseshoe kidney, because of the anatomical location, it is difficult. And marked hydronephrosis or scarring is there. Then also to localize it is difficult. So there will be reduced clearance of the stone in such conditions. Okay, is it clear? This they are asking many times. What are the various factors associated with reduced stone clearance? Clear? Not clear? Yes, no?
So this reduced clearance, are we talking about just one modality of ESWL or all sort of stones?
Only ESWL. I'm just speaking of only ESWL.
Okay.
Yeah. Give me a moment. Sorry. So somebody was asking about, this is only for ESWL. Okay. Clear?
Yes, sir.
Yeah. So what are the contraindications? And before we go into contraindications, what is the prerequisite? This is the kidney and this is stone. You fragmented it. So what will happen to the fragments?
It would be collected in the ureter.
Yeah, it will be collected in the ureter and it will go outside. So one prerequisite is it should have a intact opening. The outlet should be open. If this is closed, if there is some obstruction here, then there is no point in doing ESWL. Am I right? Yes, no? Yeah.
Yes, sir.
So the outlet should be open. Otherwise, there is no point in doing ESWL. Why? Because if there is outlet obstruction, the stone fragments will be there only. It will not go outside. And coming to the contraindications, in which case you should not do ESWL. What are the contraindications for ESWL? See here, you are giving shock waves from outside. So, which is the absolute contraindication? If the patient is pregnant, can we give shock waves from outside?
No.
Yeah, that is an absolute contraindication. See, patient is pregnant, patient is having a bleeding disorder. It will cause much hematuria if he is having a bleeding disorder. The patient is having urinary tract infection, it will cause sepsis. The patient is having unrelieved distal obstruction. If the distal obstruction, the stones will not go outside. So in these four conditions, it is absolute contraindications. Remember, BP, IO, bleeding, pregnancy, infection, obstruction. And if the patient is having cardiac pacemaker, uncontrolled hypertension, weight is more, obesity, severe renal failure, aneurysm, severe orthopedic deformity. Once they ask this, why orthopedic deformity? If the patient is having a severe orthopedic deformity, ESWL is a contraindication. Why?
Due to fractures.
Sorry? What orthopedic deformity I am talking about?
Like scoliosis?
Yeah, scoliosis or kyphosis. The patient, we can't seat him on the couch. Okay, so the spine is deviated. So in such cases, we can't do a ESWL. So remember the four absolute contraindications, that is from our level, and for next level, remember the absolute relative contraindications like cardiac pacemaker, hypertension, orthopedic deformity. These are all the other things. So complications. Whenever you are giving shock waves, you may damage the kidney, acute renal injury, and later it may cause chronic renal injury. There will be surrounding injury to the lung, injury to the bowel. There will be extracestoles infection. Most common is pain. The side effect, most common complication is pain. And what is the strain stress? Anybody? Strain stress. What is this term strain stress? It is nothing but it is street of stones. Street of stones. See, whenever you do a fragmentation, you do a kidney fragmentation, the stones will be lying in the ureter. This is street of stones. Okay, that is a complication of USWL. They'll ask you, strain stress means street of stones. Street of stones. It is a complication of ESWL. ESWL, is it clear? Please answer in the chat box.
Yes, sir.
So,
See, ESWL, we discussed about what is ESWL basically, extracorporeal shock lithotripsy. How we will deal with the various type of stones, size of stones, location of stones, what are the stone factors, like which are easily amenable, which are difficult to amenable. Okay, and then we discussed about complications, we discussed about contraindication. Next is PCNL. What is PCNL? Percutaneous nephrolithotomy. Here, see here, the surgeon will be standing like this, the patient will be on prone position. We'll just put a puncture into the kidney, we'll put the scope inside, we'll then blast it with our instrument. This is an invasive procedure, minimal invasive but invasive. So this is the indication is large volume, more than 2 centimeter stone, PCNL is the option. Staghorn stone, PCNL is the option, ESWL won't work. Obstructive uropathy, see if there is obstruction, ESWL will work or not? If there is obstruction, will ESWL work or not?
No, sir.
No. Okay. In the same way, other modalities failure, like ureteroscopy failure, ESWL failure. Lower pole stone, ESWL will work or not? Lower pole?
No, sir.
No. Difficult stones for ES. So all the contraindications for ESWL, all the various misconceptions about ESWL are the indications for PCNL. Remember like that. Okay. Whatever ESWL is not doing, PCNL will do. Okay. So here the complications are, you are putting a needle inside, so you are puncturing. So there is always the chance that you may injure the pleura, you may injure the colon, you may injure the spleen. The most commonly injured is pleura, because the kidney will be like this, the lung will be just above it. So the pleura will be just lying like this. So when you put a needle, there is always a chance that you injure the pleura. There will be bleeding, there will be urinary extravasation, written fragments, and sepsis. These are the other various complications. Okay. Clear?
Yes, sir.
Yeah, and finally, RIRS. RIRS is retrograde. Just remember the name, retrograde intrarenal surgery. Here, there is no need to put a hole inside the kidney. Just we'll pass a scope, laser scope from below, and we will fragment the stone by using laser. Okay. So this is the third modality, laser. Retrograde intrarenal surgery. And finally, they just put this picture. What is this? This is stent. This is a double J stent. Double J stent. It has 2 J's, so that 1 J will fix in the kidney, 1 J will fix in the bladder. Okay, it's a double J stent. So in any kidney operation, in any kidney surgery, we have to put the stent. Why?
Because infection should not.
Because
Infection should not be.
infection. Okay. Any other reason? Whenever you operate, there will be some edema. So the tube, these are all small tubes. Ureter and all are small tubes. So they will collapse. So to prevent the collapse, we'll put a something inside to splint. That is nothing but a stent. Okay. So they may just give this slide, and they may ask you, what is this? So identify the device. This is a double J stent. It has 2 J's which will fix in the bladder and which will fix in the pelvis. Coming to the ureteric stones. So we have discussed about the bladder stone, kidney stones. So now we'll discuss about the ureteric stones.
Could you tell me again about this RI, please?
Yeah. RIRS is nothing but it is retrograde intrarenal surgery. Why it is retrograde? See, urine will be coming from kidney to ureter. This is the antegrade route. So here you are going retrograde. From below you are putting the scope. From below you are putting the scope. You are putting the laser. It is going inside until fragmenting the stone. So it is retrograde intrarenal. You are doing whatever you are doing. It is in the kidney only. Retrograde intrarenal surgery. Clear? Clear, everybody?
yes, sir. Do we use any laser in it?
Yeah, we use only laser. RIRS
Only.
means laser only, no other thing. Okay.
Okay, sir.
Yeah. And coming to ureter. What is the size cutoff for ureter?
6 to 7 millimeters.
7 mm. Okay. This is the size. Okay. So for ureteric stone, you have to, the treatment option is URSL. URSL. What is URSL? Anybody? URSL.
Ureteroscopic lithotripsy.
Very good. Uretero reno lithotripsy. It is lithotripsy. Ureterosrenoscopic lithotripsy. Okay. You just put a scope from below. You just put a scope from below into the ureter. Okay. You do lithotripsy. That is ureterorenoscopic lithotripsy. Okay. So whenever the stone size is more than 7 mm, you can do a ureterorenoscopic lithotripsy. This is also retrograde. You just put scope from the below and you fragment it. Okay. This is about kidney stones. Any doubt? Anything you want me to repeat? Just
It's fine, sir.
yes. Hello. Yeah. Sorry.
Yeah, it's fine, sir.
Okay. So this is something about ureteric stones only, but this is all not necessary. Just remember URSL. This is little old. ESWL, but little old now. The new guidelines will suggesting only URSL is the treatment option for ureteric stones. URSL. So now coming to the bladder stones. A stone in the bladder. What is the most common kidney stone?
Calcium
Calcium
oxalate.
oxalate.
Most common radiolucent kidney stone.
Uric
Uric
acid.
acid.
Most common bladder stone.
Calcium oxalate.
No. It is ammonium urate. Mixed urate. It is known as urate stones. Urate stones are the most common things. Okay. Calcium phosphate is most common in prostate. P for P. Prostate is for prostate. Okay. Calcium phosphate is more common in prostate. Calcium oxalate in kidney. Urate is most common in bladder. Can anybody tell me in gallbladder what is the most common stone?
Mixed stone.
Sorry?
Mixed stone.
Mixed stone. Very good. In gallbladder, mixed stone is the most common thing. Okay, good. So, coming to the bladder stone, it is of primary or secondary. Two types are there. Primary stone or secondary stone. Primary stone means there is no infection. It is formed inside the bladder. It is seen in children. Primary stone. Secondary is due to infection or some obstruction. Okay. Primary is there is no infection or obstruction. It is formed primarily in the bladder. Secondary is due to infection or obstruction. So what is the treatment option here? What is the treatment option?
Medical management.
No medical management for bladder stone. Any bladder stone, only option is surgery, no medical management.
Cystolithotripsy.
Very good. Earlier days, it was open. See, suppose this is the bladder stone is there, we have to open it and remove the stone earlier days. But nowadays, what is happening is, we put a scope from inside, we break the stone. This is known as cystolithotripsy, CLT. Cystolithotripsy. We put a scope from the bladder inside and break it. Cystolithotripsy. Remember this. So today we are introduced to ESWL, PCNL, RIRS, URSL, and this is CLT, cystolithotripsy. Cystolithotripsy. This is the bladder. This is the urethra. You put a scope from urethra, fragment the stone and remove it outside. Cystolithotripsy. Okay. What is the contraindication for cystolithotripsy? Guess and tell me. Just guess and tell me.
Large stones.
Large stone. Good. Okay. Then
BPH.
BPH. Okay. Anything better than BPH? If there is narrowing of this urethra, what is that known as?
Stricture, urethral stricture.
Stricture urethra. Very good. So in stricture urethra, you can't put the scope inside. So in such cases, what you will do?
Suprapubic surgery. Suprapubic surgery.
Suprapubic?
Surgery.
Suprapubic surgery. Okay. That is nothing but you do PCCLT. It is percutaneous cystolithotripsy. You put a small hole near the bladder, put the scope inside and fragment the stone. Okay. It is percutaneous cystolithotripsy. So you discussed about what is the most common type of bladder stone, primary, secondary type of stone, bladder stone symptoms, surgeries, two surgeries, CLT, PCCLT. CLT is for normal bladder stone. If it is large bladder stone, if there is obstruction like BPH or if there is a stricture, you put a small hole and you do PCCLT, percutaneous cystolithotripsy.